Hi all, I'm Laura Targownik. I'm here with you today for our 13th episode of Transnormal, where me and my co-host Joe Ellis advocate and provide perspectives on contemporary trans issues from the perspective of transnormality, the idea that we should be supporting and embracing of trans people who transition with the goal of leading normal lives, however you define it. Once again, I'm sorry Joe isn't here with me today. She remains on vacation. She's actually returning later today, and she will be with me for our next episode. But I'm very excited by our guest who's here with me today, who is one of the leading experts and scholars on the study of gender detransition, and his name is Dr. Kinnon McKinnon. And the reason I want to bring him on is, of course, detransition has been one of the central narratives that's been used to cast doubts about the benefits of undergoing gender transition, especially when it's applied to adolescents and young adults. This was once thought to be a fairly rare outcome, but we've been seeing more and more stories of people, mostly people born female, who've decided that often after many years of medical and surgical interventions, and having transitioned, to go back to living as their natal sex, and often expressing profound regret about that experience of having transitioned, and expressing a lot of anger about people or about people and the medical system that compelled them, or that where they felt forced to have undergone this gender transition. Now, obviously, I think anyone who has a bad outcome, whatever the medical situation, is very deserving of our sympathy and very deserving of medical care. But one of the concerns among the trans community is that these stories have often been weaponized in service of a larger project which aims to end gender transition, if not only for adolescents and young adults, but for all. And so the story is obviously, like any story, it's much more complicated than the version I'm given, which is why I think it's great to have Dr. McKinnon with me. So just to give you a little bit of background of who Dr. McKinnon is, he's an assistant professor in the School of Social Work at York University in Toronto, which is also where I live. He has a PhD in Public Health Sciences from the Dalai Lama School of Public Health at the University of Toronto, and for over a decade, his scholarship has focused primarily on transgender medicine, particularly on how sexual and gender minority people access and experience hormonal and surgical treatments. He is the principal investigator of the DARE study, which we're going to be talking about later today, which is recognized as one of the largest community-engaged research study which is specifically focused on detransition and also retransition, so going back to living in the opposite gender role that you were born on after undergoing a detransition. Kinnon also co-writes the 1% newsletter, which you can find on Substack, which examines gender-affirming healthcare with a focus on detransition and retransition and gender fluidity. You may also have come to recognize him because he wrote an incredible article about detransition, which was very sympathetic to detransitioners and transitioners in the New York Times about a month ago. It's called The Truth About Detransitioning, and I'll provide a link in the podcast at the end. And so with that, I wanted to welcome to the podcast Dr. Kinnon McKinnon.
Thank you so much for the opportunity to speak, and thanks for the great summary of some of the socio-political context around detransition.
Yeah, so let me just start off by, I always like to understand sort of what drives people and what sort of got you interested in this topic, because detransition has been sort of one of these almost like this bête noire, like an area that we often think people there was very it was not very politically correct to be looking into this area. So I think there's a lot of bravery that had to go along with looking at this area. So I'm a little interested just to understand what were the sort of the motivating factors, or what sort of led you in the direction that you decided this was going to be a productive area and a worthy area of scholarship?
Yeah, for sure. And like I said, feel free to interject if I go on for too long because I'm going to have to talk a little bit about my personal story and my
I can
research
let you cook for a bit.
trajectory.
Thank you.
So, um, so I guess first to start off, so I started my transition roughly around maybe 2008, 2009,
Okay.
socially transitioning. I attended my first trans health conference in roughly 2009. It was the Trans Pulse Ontario project that was, one of the really big, the first big kind of public health, epidemiologic trans health project that happened in Canada. And so I attended that conference, and I have spent a lot of time around trans advocacy for trans healthcare.
Now, were you already in a professor at this point, or was this sort of before your academic journey?
No, so I would have been just before doing my master's of social work at that
Okay.
time. Yeah, so I was yeah, basically finished my undergrad. And many of my friends were trans advocates. Some of them worked on that project. And many of my friends were trans. I started my medical transition around 2010. And I finished my MSW in 2011. And then I was the first, I believe I was the facilitator of the first gender affirming surgery, lower surgery for trans men that was offered at the Sherbourne Health Center here in Toronto. So it was one of the first kind of big surgical support groups that was offered in Canada for post-surgery. And that group, doing that group really illuminated to me a lot of the tensions and healthcare needs amongst trans people who are accessing medical interventions and surgeries in particular.
What were some of
And
the things that were like at that time? Like this is 2011, or in that area that, when you talk about tensions, like what were the main tensions that you're referring to there?
So during this time, there was a lot of tension between trans community in Toronto and clinicians, and namely clinicians at the Center for Addiction and Mental Health, the Gender Identity Clinic. So there was a long history of what we would call gatekeeping. So really doing a lot of fulsome assessment and even denial of access to gender affirming healthcare during that time. So the Gender Identity Clinic, and there was a lot of complaints and a lot of animosity between trans community and the clinicians and the clinic at the time.
You have the trans community saying we have the right to be who we want to be, and
Mhm,
yes, we need medications to facilitate that. And then you had, the people you're referring to, the gatekeepers at the Clark Institute, at the time,
mhm,
associated with uh, CAMH, so that basically the main the mental health organization treating or providing care to gender patients who were at that point taking more of a model of we need to protect you from yourselves. You're going to make bad choices if we just let everybody who wants to transition, and we're basically saying you can access certain people can access these services in a certain way, certain people can't. And the
mhm,
community was we should all have access to this because we have the right to autonomy over our bodies and
mhm.
to live the way we want to live.
Exactly, exactly. And actually, there was also a period of time earlier in the 2000s when the Ontario government had actually delisted sex reassignment surgery from public coverage. So there was also that kind of happening as well. But you're exactly right. So I've never seen any, really definitive statistics on this, but I believe that it was, only roughly maybe 10 to 15% of trans adults were being referred for hormones and surgeries at the time. And so there was a lot of feeling of denial of access to care. And that was really felt very acutely amongst trans people. And I was made very aware of that as someone who was a young trans person at the time. So I had that history was kind of I carried that into my doctoral work in public health. So when I was doing my PhD, I started that in 2014 and I finished in 2019. And so I was really interested in how are clinicians conducting psychosocial readiness assessments? How do trans people experience those assessments? And this was also the time in which there was kind of this zeitgeist around the informed consent model was starting to be scaled up. Some of the assessments were being relaxed around that time, and the gender affirming model of care was starting to really ascend into the kind of clinical philosophies. And so it was kind of an interesting time to be collecting data. I interviewed a number of clinicians and trans people, and I studied really in depth the World Professional Association of Trans Health, their standards of care. I looked back, looked at a lot of the historical standards, the most at the time, the Standards of Care 7, which was published in 2012, was implemented. And so something interesting happened in the SOC 7, which is that the what was previously called the real life experience test, or the kind of the period in which trans people had to undergo a social transition and live in their kind of target gender, that was removed from the SOC
And this was
7.
often without having access to hormonal therapies. So,
Yes,
so that was a
exactly.
time when the real life experience was supposed to be you're going to dress up or essentially try to take on the role through cosmetics or through appearance, but without the hormones that often facilitated the ability to actually be recognizably a member of the other gender.
Yes, thank you so much for clarifying that. So yeah, and often clinicians might request a letter of proof from employers, educators, friends, family to confirm that the criteria of the real life experience was fulfilled before providing access to hormonal therapies. And so there was a lot of pushback from community, and even some clinicians felt that that was unfair and that it made trans people more vulnerable to kind of violence, discrimination, and so forth. So
Understandably, yeah.
that was removed in the SOC 7. And at the same time, I think the other kind of important change that happened in the SOC 7 was recognizing non-binary transitions. So non-binary people, for the first time, were formally recognized and able to access medical transition.
So, so,
Um,
so you know, if you know, and this is going to come up later, but when we're talking about sort of the old sort of gatekeeping system, the goal at that point was they were looking at people who they deemed to be, for whatever criteria they use, and these are often highly subjective, who were going to be the best candidates to be able to live in the role of the opposite sex and be recognizably a member of the opposite sex, as opposed to what is actually going to make this person feel better.
mhm,
So you have a number of people who maybe because of physical factors, because of lifestyle factors, or because just of lack of interest, were not as interested in being members of the recognizably binary member of the other sex, but where treatment was going to make their lives materially better in some, or maybe not materially better, but their self-perception of their self would be better. Those people were often denied care under the gatekeeping model, under the grounds, well, you're not really interested in looking like a woman if you're born male, or you're not interested in looking like a male, or I don't think you're going to be able to pull this off because you're too short, you're too tall, you're too broad, you're too this,
mhm,
or your lifestyle will not be conducive to, to this. You have children, you have a job that is non is more traditional with your if you're born male, you're a construction worker. If you're born female, you're an esthetician or something of that nature. That
mhm.
wasn't that may not be a good fit for your new gender.
Absolutely, absolutely. And so, um, the gatekeeping model was really predominant all through the 1960s, 70s, 80s, 90s, really up until the early 2010s.
Yeah.
So that legacy has been really palatable in Toronto, especially just because of the Clark, or what later became known as the Gender Identity Clinic here in Toronto.
So when you
Um,
first started writing about detransition, and when you first started getting recognized as writing about detransition, did some of these things come to pass? Like, what was the way you describe it sounds like a very sort of dispassionate way, and by that I mean sort of a way of saying yes, this does happen. We've seen it happen. These people deserve care. They deserve sympathy. Sounds all very appropriate. What was the reaction that you got when you were telling these stories, both from the trans community
mhm.
as well as from people who might be sort of predisposed to be in opposition to, accessing trans care?
Yeah, so I think I have to fill in a couple gaps first
Okay.
before I answer that question, but I'm happy to get there. So essentially around in 2020 was when Bell v. Tavistock started garnering more media attention, and specifically one detransitioned young lesbian woman Kira Bell, who was gave testimony. And so I started reading a little bit more about detransition. And I felt that there must be, it wasn't that I didn't necessarily, it wasn't that I didn't believe the testimony, but I thought that there must be a more complicated story than what the media was telling. And so that was part of my impulse to write my first grant to do a qualitative study into detransition. I could tell from looking at the literature that there wasn't a lot of research on detransition and regret. And what was done was primarily looking, using administrative data or, nothing from the perspectives of people who actually had lived experience of detransition. And so I wrote a first grant. It was funded by the Social Sciences and Humanities Research Council.
The main funding agency for social research in Canada.
Yes, yeah. And with a team of trans, non-binary, and other LGBTQ plus health researchers who were co-investigators with me. And we interviewed 28 people who detransitioned or retransitioned. Um, and it became pretty clear to me that once I started interviewing people that there wasn't a complicated story here, that there wasn't just one experience of detransition. There were people who detransitioned with really strong regret, and there was others who actually felt appreciative of their opportunity to transition. They were maybe evolving in their gender expression and identity. And then there was others who had a more temporary detransition that seemed to be driven more by external factors, discrimination, lack of support, and they had a tendency to retransition once they had, appropriate supports in
So
place.
the main narratives, like if I recall correctly, the time around Bell versus Tavistock, so you're talking about Kira Bell, sort of this lesbian woman who went through the gender identity disorder service in the UK, and later detransitioned and sued the Tavistock, which was the main care provider for youth and young adults who were, I think, or actually just youth who were gender transitioning at the time. So you have these two competing narratives. One was that the trans community or trans advocates were really trying to say this is a one-off, or this is exceedingly rare. This shouldn't be thought of as a common outcome of gender transition. This person had her own unique circumstances. I think there was often an attempt to portray her as being not necessarily as making her own choice, and dealing with fact and having other factors that were very unique to her that causes detransition, and that we shouldn't really consider her story as emblematic of the trans experience. And then you had other people who were opposing gender transition were kind of saying, this is, these outcomes are common, and this would almost be the expected outcome given the way that the gender identity service was pushing people through transition who may not have been optimal candidates or who may not have really needed this type of intervention. So I understand the importance, like as a scholar, of wanting to understand that experience more when you have these two competing narratives, both of which could be true, but obviously you're both being used in service to advance a political mission, one to keep trans care going and one to try to stop it from existing.
Hmm.
Yeah.
Yeah, you're right. You're right. Yeah.
So you're doing this research and um, you find that there are from a relatively small sample. Let me
Hmm.
put it this way: small sample in terms of 28 people, but at the same time, there are 28 detransitioners here. Now, um, how does this fit with this sort of common narrative? Like, when people used to quote detransitions, or and often still do quote detransitions, that they will still say things like regret is rare. And they
Hmm.
quote meta-analyses, for instance, that say that regret happens in 1.3% or some number in that neighborhood
Hmm.
of transitions.
Hmm.
Yet at the same time, you get 28 people. And one of the challenges we have is that's a numerator. Like when you're looking at it scientifically, we don't know out of how many people that is. So when you look at that study, I think a lot of people look at it like you've described as, oh, we got 20 people, we heard their stories. There's different reasons. Some do it, some detransition for reason X, some detransition for reason Y, and others look at this and go, oh my God, there are 28 detransitioners out there. That's a lot.
Hmm.
Um, so when you published this paper, how did you find that people were actually framing your results in the popular discourse?
Yeah, it's been pretty interesting. So me and my colleagues have
Yeah.
published a number of papers at this point, we'll get to the DARE study later, which was a much larger study. But what I find is that people apply their preconceived narratives to interpret the results of the study because I think because me and my team have been, we have basically presented what the results that we've found, which actually is heterogeneity, it's complexity. There are these different experiences, as I've mentioned. So people who tend to, I think, see detransition as largely driven by societal factors, discrimination, they tend to really focus on those experiences, those stories, which is absolutely there in
You
the
say
data.
the transition is hard story, like in a sense.
The Yeah, like being trans is really difficult and it's
Yeah,
difficult to go on,
and
which
sometimes
is
it's too
is
much.
absolutely true for
Yeah,
some people. I would never deny that. Um, and then the other people who may be more inclined to see detransition as evidence of a failure, a systemic level failure, and with deep regret, medical harm. Those stories are also there. But people who are, I think, primed to see those stories will focus more strongly on really amplifying
yeah.
those results.
Or
But
people.
no, it's more rare to see someone who actually can see to see the full scope of the
Yeah,
results.
yeah, and I think that like as scholars we appreciate that because like I find this a lot on both sides is people will latch on to whatever data set happens to be more in line with the narrative that they want to be true. So
Hmm.
if you are someone who thinks detransition is rare or that it's medical or that it's so rare as to be unimportant or not so common as that we should be considering it as a reason to stop providing care, they're going to latch on to studies that say that most people who detransition because of these external factors. That when you
Hmm.
transition, there's so much stigma, your life gets hard, you lose your job, you lose your friends, you lose your family, you lose a source of income that gets you down. It becomes too much to manage at some point. You decide, you know what, I'm still dysphoric, but I'm going to go back and live like I was before because I can't deal with all the trouble of being trans. Whereas people who really want to stop this are kind of like, no, no, people are being harmed by this, and look at these stories that show these that really highlight these stories. Um, these stories of regret. So so it's so obviously it's important to understand that this is a heterogeneous you know uh, a heterogeneous process. So I want to move into sort of more your more recent work. So you talk about the DARE study, which I had a chance to take a look at the pre-proof, and fascinating work. But I want to hear about sort of what was the motivation behind or getting the why did you decide this needed to be further studied? What did you think that having a larger sample was going to get you? And what are the key insights that we can take home from this?
Hmm. Yeah, so I think first I wanted to kind of say a little bit about my kind of position as a researcher and also the principal investigator of the study, which is essentially that I mean the DARE study it tries to be apolitical and really not necessarily taking a strong side in these very heated debates.
Yeah,
However, I would say that if I have any position, it is that detransition is an experience that deserves to be studied,
yes,
in particular with regards to being considered in kind of clinical decision making, access to care, because I think going back a little bit to the one of the key findings from the initial pilot study was that people were detransitioning and avoiding healthcare. Some of them were essentially being rejected from trans and gender diverse communities, experiencing, losing their social networks, and they were quite isolated. And I found that to be very concerning. And so that was essentially why I carried on in this work. But the DARE study is not being conducted as and thinking about your podcast in terms of like a kind of integration or normalization kind of project. That's not
no,
necessarily the objective of the DARE study. Um, and it's not. I wouldn't say it's say like a trans medicalist project. Its main objectives are to understand and build academic knowledge about detransition, retransition, gender fluidity, decisional regret, really with the aim of supporting people and improving gender affirming healthcare
and this
specifically.
makes sense because, as you say, but this was thought to be such a rare outcome that we had no idea, for instance, even how to medically manage people
Hmm.
who transitioned. And I understand the reports too of people who have been seen in gender affirming care clinics. I can understand the stigma that would be associated with trying to go back to that same doctor and saying, I'm out, or I'm dissatisfied with this process that I've been through, or even I was satisfied with it, but I don't want to look like a disappointment to you. All these different factors that might lead someone to be sort of feeling alone. And, so I understand completely the notion of, this could be your child, this could be you. Um, you want anybody who's suffering, whatever they're suffering from, whether it is from being gender dysphoric or
Hmm.
whether it is from having gone through a transition that didn't work out, of being able to get the care they deserve and live their best life.
Hmm.
Yeah.
Yeah, yeah, exactly. That's exactly, yeah, some of the themes that come out of this area of research. Yeah, so the DARE study, it stands for Detransition, Analysis, Representation, and Exploration. And I'm the principal investigator. I'm joined by a number of other Canadian and one American researcher. We're all essentially LGBTQ plus health researchers or allies. A couple of people on the project, either as co-investigators or research assistants, actually do have detransition experiences, either stopping or reversing gender transition. And we also did, in the early phases of the study, a lot of community consultation around naming, around pilot testing the survey with trans people and non-binary people, detransitioners, to make sure that the survey was essentially, making sense. The language was, making sense for both communities, a range of different experiences and so forth. So the study is a mixed methods project. So meaning that we are collecting quantitative survey-based data, as well as we followed up with 42 in-depth interviews with people. And we did something kind of innovative, which is we did a latent class analysis. So this is an approach to when you have a very heterogeneous population, you can apply this statistical method
Yeah.
to identify that are like qualitatively homogeneous subgroups that exist within this like big much larger population. So we applied a latent class analysis, and we identified four subgroups that they have characteristics that are much more similar to each other.
Yeah. So
So we
basically,
have
four categories of detransitioners.
exactly, yeah, exactly. Um, and then from there, once we identified our groups, we were able to then do some more further analyses to look at like what are the characteristics of each of these groups? Are there some similarities? Are there major differences around a number of different variables? And then from the qualitative phase, what we actually did was interview people who were essentially representative members of these four groups and hear a little bit more about their life experiences, their gender identity development, their transition, their detransition. What were their experiences of gender affirming healthcare like? What were their experiences of detransition, and in some cases, retransition?
So tell me
Like,
about these four groups, because I think this is really important.
yeah,
That you had nearly 1,000 people. You did a bunch of surveys, like you said, about who they were, where they came from, when they transitioned, were they assigned male at birth, assigned female at birth, or natal males, natal females, how long they transitioned for, all those types of variables, and you identified that there are four categories. So
mhm.
what are those four categories?
Yeah. So, yeah, just to mention, it was done in the United States and Canada, and a large majority are Americans in the study, and that's probably likely due to just population size, I'm gonna guess. But yeah, I think roughly somewhere between around
And
I think
how did you
70 to
find the
70.
detransitioners? Was this a sort of mail out, or was it like sort of advertised on social media, or sort of the news was spread between friends?
All of the above. So we did a lot of paid online advertising. I advertised through my own TikTok account where I had a number of followers who were people who detransition. We essentially scanned the internet really. It was, Reddit, Facebook, Twitter, Tumblr, all of the social media. I believe we targeted with ads. It was definitely over 50 private groups.
Yeah, great.
Um, some of them, and we were not only targeting detransition groups, by the way. It was a lot of LGBTQ plus. a lot of generalist groups, also detransition groups.
So
Um,
reaching out to a lot of different places where detransitioners might be, and also presenting yourself as being sort of welcome to whatever detransition experience you had, of being sort of someone that you'd feel comfortable to talk to. Because you don't, one thing you don't want with these kind of surveys is for someone to think you're on one side or another side, and then you only get the people who agree with you to kind of participate in your survey. You wanted to make sure you were casting a very wide net, and also being
mhm.
very welcoming of a detransition experience, no matter what kind of detransition experience you might have.
Yes, absolutely. So we were, yes, and that effort was largely trying to address selection bias that has occurred in the in prior studies, essentially. So studies that are either designed for more for understanding trans people's experiences of kind of forced detransition versus people who've had more of an internal detransition and they more conceptualize themselves as detrans or detransitioners. So we wanted to have a study that welcomed everybody into, regardless of what your pathway to, transition and detransition was. And so we did the a lot of internet-based sampling, but we also shared flyers with gender clinics, and I know that the flyers were posted in some gender clinics, as well as student organizations at universities, LGBTQ plus organizations, and then we also emailed, I can't remember the numbers. It must have been, I believe it was over 500 gender care providers across the United States and Canada.
To try to
So
identify people and their practices. Yeah.
yeah, we really tried to make sure that everyone who was possibly eligible had the opportunity to be invited and participate if they wanted to, volunteer to participate. So we ended up with, again, a very heterogeneous sample. I think our sampling strategy did actually work quite well to invite and include a really wide range of experiences. Um, so yeah, we had, as I mentioned, a majority, close to 75% were coming from the United States. The mean age was 26 years old, so it was a younger sample. Um, and we had 78%, around 78, yeah, I think it was 78, 79% were assigned female at birth.
Yeah.
Um, and it was a large majority sexual minorities. So, actually, a majority were plurisexual, bisexual, pansexual. And then we also had a number of lesbian identified people, as well as some gay men were in the study at a much smaller number. And then a lot of non-binary people who had current trans identities were, I think, roughly about 42% of the sample had a current trans identity. Um, I believe it was around 42% of the sample had an experience of detransition and then retransitioning again. So there actually was, the sample seemed to
So people
have.
are very fluid in the sense of going back and forth between identifying as trans or identifying maybe as non-binary or identifying in with various sexual identities or conceptualizing their identity in a lot of different ways.
Mhm. Exactly. And so, um, yeah, to me, some of what we were seeing in terms of the characteristics of just the broader sample is somewhat consistent as to what we see when we look at gender diverse youth samples today. So we see a lot more gender fluidity. We see 70, 80% are assigned female at birth. A large majority being white is another characteristic that we saw. I think 75, 80% of our sample was
So,
white,
so
which.
if we get to the results, so we have these four groups,
Mhm.
and and so what were the main differences between these groups?
Yeah. So then, okay. So I was just talking generally about the
Yeah,
uh,
yeah.
general demographics
Of
of the
who got into the study?
then we applied the latent class analysis to identify these four different groups. And we labeled them just A, B, C, and D. There was internally we thought we were kind of like, should we try to give these groups a name? But there was, some of our team members thought, you know what, let's not name them because we feel that actually that needs more community consultation in terms of actually giving them a name. So they're called Group A, B, C, D. Group A and D are the largest proportionally of the sample. Group A is probably more what you think of when you see media representation of detransitioners. And so they were, compared to the other group, they were more assigned female at birth, basically 90% assigned female at birth. Um, 15% had a current gender diverse identity, but the rest, so 85%, did not conceptualize themselves as transgender or gender diverse. They would have identified with their assigned gender at birth or sex, and they also some of them also identified as detrans.
Yeah. Now,
Uh,
these made up about a third of your sample, correct?
yes, so they
And I
were,
recognize
yeah,
we can't say this is like a third of all detransitioners because there might have
yeah,
been selection biases. People who wanted to tell that kind of story may have been more likely or less likely to want to tell their stories to you. But in
yeah.
any case, this was a significant part of your cohort, and we might call. I know you didn't want to label them for the reasons you outlined, but these are the kind of people who we would recognize as the regretful detransitioners.
Yeah, for the most part. But again, I want to like point out that there was 15% of that sample who still do label themselves as trans. So they would probably be regretful people who have a lot of regret, but they still might live their lives as trans. So they're also
That'd be kind of wish they wouldn't have done it if they could do it over.
yeah, yeah,
Yeah.
yeah. So again, within that group, so it's about a third of the sample. Um, in terms of sexual orientation identity, compared to the other groups, they had a lot lower levels of plurisexuality. So they actually were predominantly monosexual. We had a lot more gays and lesbians, as well as heterosexuals in that group. The other groups had a greater proportion of bisexuals
Now,
or
one question I have about this group is were these do we know if these people who detransitioned, I know they're primarily natal females, were they more likely or less likely than other groups to have experienced gender dysphoria or be diagnosed with gender dysphoria or to recall their experience as being consistent with gender dysphoria?
that I can't really speak to. I don't think we have sufficient data to say that. We did interview a number of people from that group, but I'm not sure if those interviews are necessarily representative. But I would say that so compared to the other groups, um, they it was the greatest number of people who started their transition as minors, and across the whole sample, we had, I think it was just under 30 who had surgery as minors, and almost all of them were in that group. So they generally had access to gender-affirming healthcare at younger
At a young
ages in
age.
comparison to the other groups, and they had the strongest regret. So
And were
we
these
have,
also people who, like, when we think of sort of what people in the trans community often, the people whose stories are often most politically useful to people who are to the groups that are trying to end the project of, let's say, pediatric gender transition,
Mhm,
we're often talking about, the common narrative, and these are people in the media like, uh, you know, Chloe Cole probably being the most prominent example,
mhm,
Christian Mosley, those types whose stories have been really compelling in a
mhm,
way of driving the narrative that gender transition is bad,
mhm,
or that this is something that is medically inappropriate to be offering people. But what seems to be characteristic is these are people who are primarily male female,
mhm,
often with significant mental health comorbidities, and
mhm,
who are medicalized not necessarily because of gender dysphoria or because their gender dysphoria was sort of enmeshed in a lot of other sort of personality and um,
mhm,
uh, psychological comorbidities that maybe would raise the question as to whether the gender dysphoria was a primary diagnosis or whether it
mhm,
was something that
mhm,
was induced by other psychological or personality related factors.
mhm, mhm. Yeah, absolutely. And I would say that compared to the other groups. So there is one other group, Group C, which was about 20% of the sample, who actually shared some more similarities with Group A, in the sense of essentially, yeah, co-occurring mental health challenges. I would say with Group A and C, they both had the highest decisional regret scores with both social and medical transition. They also both had the highest adverse childhood experience scores,
Yeah.
and they also had the highest levels of eating disorders, obsessive disorders, trauma-related disorders. I believe they were also the highest in personality disorders as well. So
Now,
I
do you
think
think that things
it's
like resilience or like those those types of measures, like the reason I ask is like when we're looking at people who are if you are unfortunate enough to have those type of psychological comorbidities, and then you
Mhm.
throw gender dysphoria on top of it, and a transition on top of it, and whether that dysphoria is, let's say, real dysphoria, whether it's induced dysphoria, whatever it might be,
Right.
that if you're managing a lot of psychological comorbidities and maybe you're neuroatypical, that the
Hmm.
challenges of successfully navigating a transition become significantly more difficult,
Yeah.
especially if you don't have, let's say, the significant mental health support one would need to successfully manage that transition. And
Hmm.
then so I'm saying if you throw dysphoria and transition on top of that, it's
Hmm.
unsurprising to me that these people probably also lack things like resilience or have poor
Hmm.
coping skills, and the challenges that any transition poses are more likely to be overwhelming to someone in
Hmm.
that situation.
Yes, I think so. I would absolutely agree with that. And I think the other piece that was especially I think important to point out in the group A is that also less than 50% of this group, so it was the lowest across all the groups, did reported access to decision-making support such as an assessment or therapy, like kind of talk therapy. Whereas some of the other groups that had lower regret or even mostly satisfaction with their transition, they reported actually higher, much higher access to decision-making
Consistent with
support.
almost this ultra affirming model of you come in, you say you're trans, here's your testosterone, or here's your puberty blockers, which is sort of this, I'm not saying this doesn't happen, but this is once again the narrative that is often used by opponents of trans care, saying people are being rushed into, like this group of detransitioners have the perception that they were being pushed or rushed into transition, or that a decision was being imposed on them as opposed to there being this sort of drawn out process of shared decision making.
Yeah, and what I would say, what I would also add is that a number of the individuals who did have strong regret that we interviewed, mainly from Group A, some of them did actually seem to go through a sort of therapeutic process. But in hindsight, what they would tell us in the interviews is that essentially, in hindsight, they felt like, maybe in a therapeutic process, they had come in previously for other issues that they needed help with, and then once they sort of declared a trans identity, essentially that all of their
That came
distress
to the
was
front.
explained, yeah, was explained by the trans
Oh, you got trans
identity.
identity. That's why nothing's working out for you. If we just solve this problem, then everything is going to be hunky dory on the other side,
Mhm.
or it'll be so
That
much
was
easier to deal with once you deal with your gender.
Yeah, and so that was
Yeah,
the experience that they presented to us. And I think the other, I want to just talk about a bit of nuance because you did mention a couple of like very high profile detransitioners, and I would say that we do see experiences like that in the literature, not only my study, but many studies. But when you actually sit down face to face with people who have these experiences, it tends to be a lot more nuanced than what you see blown up on social media or the media. Um, you know, they're
yeah. Like
I
there's
think
reasons why those stories are being highlighted in platforms now.
yes.
Yeah,
Yes,
yeah,
absolutely. So, like just thinking back to the introduction and the description of detransition. So, I have interviewed myself over Zoom or members of my research team, like probably over 100 people who've detransitioned, and only I think like only a couple of those people have actually really strongly felt that. that gender affirming healthcare should be, banned, or they would support this project of eliminating trans medicine.
Very
But
interesting.
many of so I think though those feelings, while they are true for some people, they're not representative of most detransitioners, even those who have really strong regret. And I can't speak from, we've never polled all detransitioners, so I can't say the
The
proportion
people
of
who,
people.
yeah, yeah, like obviously I'm not going to ask you who you interviewed, but it would strike me that the people who are most strongly politically against the project of gender affirming care are kind of the people who may be less likely to engage with you.
Yes,
Hmm.
that has been my experience. So even though tried to be open as a researcher to all experiences of detransition, because by virtue of being trans myself and being connected to W Path
And you're a trans affirming person.
conferences,
Yeah.
some there are some people who tend to not be mistrustful, and that's for a number of factors, but
Yeah.
it may be in part due to feeling actually quite let down by this organization. So, but anyway, but I'd love to get back to talking
Okay.
about
Yeah,
the
so
other
the other groups,
the other
because
group.
yeah, I guess the other main group that probably is of interest is probably the polar opposite A's, which I think were the D's in your
Yep,
study,
yep.
which were the people who, um, when we used to think about transition, like the traditional story of detransition, which were the people who were, I guess my term, one saying, I know you don't want labels on it, but people who found the transition experience to be overwhelming and
Hmm.
made more expedient decisions about detransitioning or practical decisions about
Hmm.
detransitioning as opposed to a change in their gender identity.
Yeah,
Like
absolutely.
people who in a perfect world would still have transitioned.
Yeah, yeah, yeah.
Yeah.
So group D was really, yeah, you're right, like almost like um, looked quite different in terms of characteristics. They tended to um, feel that their detransition was more driven by discrimination, lack of support, and then also lack of access to gender affirming healthcare. So it was really, we might call that like an involuntary detransition or an interrupted gender transition. So, which is another research team has kind of coined that term, interrupted gender transition. Walls et al. There's a paper on that experience. They were about 95% had current trans identities. Um, we did see a larger proportion, though still a minority, of people who were assigned male at birth in that group. So, if I recall, it was around 36% or so.
But one of the interesting things, like when I was literally digging through your data a little bit, is that of all the assigned male at birth, of all the natal males in your study, they were most likely to be like almost more than half of the males in your study were in that group.
Yeah, yeah, yeah. So for sure, yeah. So it was largely trans women in the study were typed into that group.
Yeah.
Where they also came up a little bit more was in the group C as well. So we that's where we saw, and that in that group. So that group was like multifactorial in terms of the reasons that they detransitioned. But if you look at the way we put these on these radar plots
Yeah.
to kind of map out how, the different reasons why they detransition, the factors. But group C, the strongest, that like the number one strongest factor was also discrimination, along with many other factors in group C. And that's also again where we saw more trans women in that group. And then in the group D was again, we also saw a lot of trans men in that group and non-binary people, but by and large, as you pointed out, like in our study, most of the trans women were in that group. In the group A, yeah, essentially it was 10% of people who they lived as trans women for some time, and then they re-identified, usually as gay men. So going back to group D, they tended to actually have a longer duration in the timeline, so the time that they actually realized a trans identity. So they realized a trans identity on average at a younger age in comparison to the other groups, and they
Even before
accessed.
puberty on a
Um, well, some of them, yes, yeah, absolutely, some of them, but the mean age was around 13.
Yeah.
But yeah, some of them would have been, I think age 2 was the youngest that we had in the survey. A number of them were pre-puberty. We applied a measure that was looking at recalled gender identity or recalled gender role in childhood. We did see slightly greater gender recalled gender nonconformity in childhood in that group, in the group D, in comparison to the other groups. And we also saw lower access to puberty blockers in group D in comparison to the other group. There was very only, I think, about 8% across the whole sample had, access puberty blockers. But
Was it
uh,
because they started their transitions later?
yeah, many of them, because most of them, well, on average, the total sample had an identity realization after puberty. I believe it was around 15.5 was the mean age. But group A was the group who did actually have access to to the greatest puberty blockers. They had essentially compared to
Now,
the other.
did you look at how much physicality played a role in terms of people's decision to detransition?
In what sense?
So I'm talking about things like, what often get referred to as passability or perceived passability. Um, I recognize this is probably more of an issue with people, trans women, or people
Mhm.
who are assigned male at birth, in terms of there's some people who where it's more economic factors, and I recognize these are kind of intertwined, and then some people where it's like I expect it to look a certain way in the world, and I'm not quite passing, I'm not quite getting there, and therefore
Yep.
I need to give this up because whatever, I can't access the surgeries I need to help me pass, or
Mhm.
I'm just really tall and I'm really broad, or if you're assigned female at birth, I'm really short and have wide hips, or other things that would make it very impossible to be uh, perceived
Mhm.
as the opposite gender, or was it sort of less of a
Mhm.
factor given sort of like a lot of the non-binary identity
Mhm.
fluidity in your sample?
Yeah, so we did ask a question on that. And I should have explained this earlier. Um, with the essentially the what we call indicator variables for the latent class analysis were a list of 21 different reasons that people made the decision to stop or reverse their transition. And one of those questions was the interventions weren't enough to. I think it was, yeah, like dissatisfaction with the interventions. The other one, what another question was. Uh, difficult with regards to difficulty with passing.
Yeah.
And what we did, that question with regards to passing, we actually grouped it in with the gender minority stressors or like kind of discrimination. So it's kind of bundled in with the other external factors like discrimination. So yeah, so we have not looked at it independently, but we do have it in there. We did also collect data on people's heights, but I think there was a lot of missing data because it was at the very end of the survey. And we have not looked at it yet. But I think that I think you raise a good point. Because I think that in particular I think with regards to trans women who are accessing treatments post puberty, and some trans men too, but I think this is more of an issue that affects trans women, that may be very well be a factor, not being read socially in the way that you feel to be authentic and
Yeah.
more
I know,
vulnerable.
I know, just speaking for myself, that was a very important factor for me.
Mhm.
And the ability to make that social transition,
Mhm.
and knowing that in order to do so, that there was a certain, I'm not going to say a standard, obviously there's a lot of different ways a woman can look, but there was a certain sort of threshold that would have to be passed that would allow me to do that without being sort of constantly being interpreted as someone with a history of gender transition.
Yes.
Yeah.
Yeah, absolutely. So I do think that that was a factor for yeah, for many of those, particularly in the groups D and also to some extent C, for
There's a
sure.
couple of things that stand out, and I want to bring this sort of into the political context a bit, which is that first of all, as you mentioned, most of your detransitioners were assigned female at birth or natal females,
Mhm.
and especially when you look at the group of the regretful detransitioners, the one who would view their transition experience specifically as this is a bad outcome, I shouldn't have done it, I regret having been put through this. Um, those are overwhelmingly female. And also or assigned female birth, and also much more likely to have these other complicating factors. Now, how one of the arguments that when I know me and other trans women talk, and especially because a lot of people like me are very concerned about how the detransition narrative is being used to fuel a political project that seeks to
Mm,
um, that seeks to other trans people, and particularly seeks to, at the very least, cut off access to pediatric services to pediatric and young adults, and potentially to all adults.
mm,
Is We often say that one of the concerns is that this is largely being driven by and I don't want to make this into a trans men versus trans women thing,
mhm,
that trans women are unique, and I mean that natal females, and particularly natal females who have these complicating factors, are
mhm,
uniquely susceptible to bad outcomes.
mm,
Obviously, some of them probably do great, or many of them maybe even do great. But if we could sort of carve off this to a different kind of care, um, that it would solve a lot of it would sort of take the steam out of a lot of uh, but that also involves gatekeeping, which I know, going back to early conversation, is something that many trans people find, they look at that as anathemic, as something that is a non-starter. So how do we take this data, which is very compelling,
mhm, mhm,
and apply that into practice, at the clinical level, but also in political messaging?
mhm. Yeah, so I think the first thing I would want to say, as someone who I guess been researching this topic and engaging with a lot of people who detransition, is that and following the politics. I think in the trans community, because of the way that certain detransition narratives have been kind of pushed out via media and also in legislative testimony, it gives this impression that detransition is like the thing that is really pushing the kind of anti-trans political project. And I agree that it's part of it, but I would not. I get kind of worried about scapegoating.
Yeah.
Scapegoating, especially, you know, usually young women who have a lot of, complex lives and a lot of traumatic experiences and so forth. I think to my mind, a lot of what's pushing the legislation is the systematic reviews of efficacy and, to what extent do we have certainty around risks and benefits. And so I think that's also a really big part of what's happening in the political realm. And detransition, if you look at some of the like detransition research, is not really a big. It's part of the legislative changes, but we have desistance, we've got systematic reviews, that kind of stuff all kind of comes together.
Like I
Um,
think, like my perspective is that's the scientific cover, but the political project is often on the basis of narrative, and
mm,
the narratives of detransitioners are very potent.
mhm,
Of someone who, let's say, if you're a parent and you have a child who's dysphoric, particularly a young, a natal female, and you
mhm,
hear these stories and you hear about what these young women have been through,
mhm,
and how their bodies have been irreversibly changed, and now they are fighting for the rights of people to not go through that kind of care. That is
mhm,
very, a very compelling narrative. And when you put
mhm,
these people on, either in social media or you put them in front of legislatures, I think those are very hard narratives to counteract. And that's a
mhm.
separate question of, do these people
Yeah.
deserve sympathy? Of course, they deserve a sympathy.
Mhm,
Um, but uh, but but one of the things that we fear is that when we apply a very light gatekeeping model, and we affirm kind of everybody, that it means that you are going to have these types of outcomes.
mhm,
We don't know how often, but we're going to have those types of outcomes. And when
mhm,
those types of outcomes occur, they are going to be obviously very damaging to the person experiencing them, but also
mhm,
very damaging to the ability of people to provide care for the people who need it, or even for And I recognize, yes, the systematic reviews haven't clearly shown that efficacy exceeds harms, or the harms exceed efficacy, but we all recognize as well that many people do experience benefit.
mhm. Definitely.
So
Yeah, so I take your point, and I absolutely agree that, sensationalized media coverage is used to push a particular narrative. So my to answer your original question, it is that at this point, I think we really need higher quality research. And me or anyone on my team wouldn't necessarily say that, this is the study that should be informing clinical decision making or policy because as you've already pointed out, it's not a representative sample. It's an exploratory, it's really quite exploratory. And I agree, I think we need a lot more research. But to your point about, although we do see, not only in my study, but many studies using different methodologies that people who are assigned female at birth actually do seem to detransition more than people who are trans feminine.
So I want to pick up on that because I think this is really a key thing, and I know this wasn't the focus of this study or of your research, but what we really want to understand is how often does this happen, and particularly how often does this
Yeah,
happen in what I would often refer to as the modern cohort, sort of this cohort
right.
is enriched with with assigned female at birth people, where we are
Yeah.
seeing more neurotypicality, where we are seeing more um, complex medical and psychosocial histories and histories of childhood
Hmm.
deprivation and trauma. Um, what so I know this study doesn't inform it, but you just went on and sort of said we think this does happen more, and it does happen more among uh, natal females. Um,
Hmm.
where are we going to get that data from?
Well, I
Or
mean,
is, or is this sort of just that mirage out in the horizon that we're really never gonna go reach? So we're all gonna have to describe it in our own words, or is this something we're gonna be able to get to the bottom to at some point?
I hope we can get to the bottom of it. I'm optimistic that there will be a push. Might not happen in the United States necessarily, given the context around transmedical research and research in general in science. But I think other I know I know that a few countries in Europe are conducting studies on detransition and regret. But you know what's I think what's interesting, and this was another, I guess, bit of information that led me to understand that something had changed is that if you look historically at the studies in regret, actually trans women had a higher rate of regret and detransition compared to trans men, and that was in every I think every study that was conducted. Not that there was very many studies on this ever
Right. But
conducted.
those also came out of the gatekeeping times, right?
Yes,
So
exactly.
being
So
gatekeeped, and I'm not saying gatekeeping good, gatekeeping bad. I'm just saying that when you did gatekeep, the kind of reasons, like my guess is that in a more stricter gatekeeping regime, that
mhm.
many of the people who eventually detransitioned would have gotten weaned out. Uh,
Yeah,
yeah, possibly.
possibly.
I recognize this is all
Yeah,
speculative.
but
Uh,
yeah, we still, I mean, interestingly, like the historically, the way that, historically, they used, the older clinicians used the term regret, and they used it really broadly to describe basically anything that was not like a binary transsexual outcome. They called
sure.
it all regret. If someone seemed to shift to kind of non-binary and, out of the role that they were expected to transition into, that was called regret. People who expressed decisional regret, that was called regret. So it was very, very broad. Um, but today, yeah, I think a few things have happened historically. Well, first, um, what we think of as trans has changed significantly. Um, Epidemiologically, the characteristics of the trans population has changed dramatically. Um, and so we do have a different population of people who have been transitioning. And also, of course, scaling up access to pediatric trans medicine was a project of really the early 2010s.
Yeah.
Um, and in Canada, we hadn't studied. I'm the first researcher to study regret and detransition since 1989. So although we had, access to gender affirming healthcare was really scaled up through the early 2010s, and in particular, access for youth, we really don't have any really high quality longitudinal studies coming out that look at our identity outcomes, health outcomes, psychosocial outcomes in Canada. And so I would, I think that that's kind of important to research to prioritize, and that's the research that should be used to to inform clinical decision making, policy making currently. I would say that, my study has value, but I really think that we need much better designed studies to
Yeah. So I know
guide these decisions.
you're not a clinician, so you're not providing direct care for patients. I
Yeah.
am a clinician, but I don't provide direct care in terms of pediatric gender care, or even gender care
Mhm.
in general. But what I'm hearing when I talk to clinicians, and a lot of these conversations are off record because pediatric care providers are very hesitant about going in front of the media for very
Yeah.
understandable reasons right now. Uh, whether it's the weaponization of their narratives or the concern about death threats, or very real and understandable reasons.
Mhm.
But I'm getting the sense that clinicians in Canada are already responding, whether it's to your research specifically or to the narrative, and that they are, even if they're not necessarily calling it gatekeeping,
Mm.
are starting to be more circumspect about how much support someone will need before they uh, prescribe medical therapies, particularly for assigned female at birth people who are seeking transition. And then we have it where it's more official policy in places like Scandinavia and the Netherlands, Finland. I think probably with Dr. I think it's Kaliakata, I'm probably mangling that name, who are applying these more gatekeeping type models of care that seek to, really be highly selective in terms of which young people get access to therapy, and probably particularly among natal females, which are the predominant patients who are being seen in clinics now.
Mhm.
Does this strike you as an appropriate response to the state of the data where it is right now?
I'm not really sure, and I tend to be a little bit reserved about giving you know, policy or clinical advice at this moment.
Fair.
Um, I do work with a number of gender clinicians, and I'm in touch with, for instance, I regularly talk to some of the authors of the W Path Adolescent chapter. I know a lot of clinicians in the U.S. and in Canada as well. So um, I'm not sure I don't know what's happening in every gender clinic, or if people are really changing their practices at this point. I think for me personally, I guess as someone who's also a parent, also a trans
Yeah,
person,
as am I.
I have my own, I have my, I also, I didn't say this at the beginning, but I do also have a number of my own, they're friends or acquaintances who I transitioned with in the early 2010s, or, some of them have detransitioned, some of them after many, many, many years,
Yeah.
with different feelings about their outcome. Some of them have deep regret. Some of them are actually, that would not be their experience. Um, I think that when you have a novel medical treatment that's just been scaled up, and there's an emerging group of people who are saying they got hurt by it, I do think and also some uncertainty
Magnitude of it.
around well the magnitude maybe, but also just the evidence base. I do think that's reason to at least ask some questions, do some more research, adopt a position that's maybe more humble, more humility, recognizing that there is uncertainty. But then again, I want to say that, like, I do think there's a need for more research at this time, and also to recognize that there is also this political project that has cast a lot of doubt around the intervention. So I think it's complicated. I myself, probably like you, trying to sort out where I stand
Yeah, like
on pediatric
you
gender
frame
affirming
it as a
healthcare.
parent. Like, yeah, like I'm a parent too. I have teenagers. They're 15 years old. So far, thankfully, neither has given any inclination of being dysphoric or having an identity different from the one that's associated with the sex that was assigned at birth. But
Mhm.
if one of them were to come to me later today and say, I've been feeling this, I would be very circumspect about initiating I'm not, not there's part that I would affirm, I like to think of a good parent.
Mhm.
I would affirm what they're feeling and saying, this is real, but I would also be very, very apprehensive about going towards a medical path. At this point, and I'm not saying I would never. I still believe strongly that that kind of care should be in the armamentarium, and
Mhm.
clinicians should have the ability to access that kind of care. But I would be very apprehensive, and I'd probably be very suspicious of someone who would say, your child needs to get put on therapy immediately. And this is very different than what I would have thought 5 years ago, because I
Mhm.
am paying attention
Mhm.
to the systematic reviews and the narratives and the experiences. And you're right. Like as a parent,
Mhm.
I want clearer answers too, and as you do, which is really. And I'm just saying that's a very difficult message to frame my personal feelings about my concern about this with still
Mhm.
making a political argument that bans are wrong,
Mhm.
and that while also recognizing that and you alluded to this too, that you don't know what the pediatric care providers do, and I suspect, like
Mhm.
you suspect, that it's probably a lot of different things because there's
Mhm.
tons of variation of care in any
Mhm.
field, and why wouldn't there be in this too? You have some people who are very aggressive, some people who are more cautious, some people who are more who do very intense evaluations, some people who don't think it's important, some people who believe in gatekeeping, some people who don't, and you're going to get all kinds of outcomes that are really highly contingent on which clinic you go to and which person you happen to see.
Mhm. Yeah, and I agree with what you're saying, but I also think that it's important not to lose sight of the fact that, I do think that for people who are assigned male at birth and having a trans feminine transition, that these are also big decisions that have really big implications on
Yeah,
people's
these are
lives.
highly
So
consequential decisions, no matter what
yeah,
you're
they're very
assigned.
highly consequential
Yeah,
either way. So, and maybe, that is true for some, like for some trans men too. Like having earlier access
yeah,
might be very, very positive and beneficial.
yeah,
It's just that I think at this point, it's just with the current evidence, it can be. It's an uncertain
yeah,
decision to some extent, in the sense of you. I think the clinicians don't necessarily have the tools to predict, f 5 years into the future as to where people are going to be.
yeah. No, I think that's fair, and I know I had this when I was talking to Dr. Guyot last week, which is that we often talk about, the start. Like if I start therapy, what is going to be outcome? But the a good practice is also not so much does this intervention work, but is this intervention working?
Hmm.
And making sure,
Hmm.
like, and I think a lot of these problems can be avoided if there is a physician patient parent relationship where there's trust and people are comfortable coming to you and saying, you know what, I'm not feeling like I was feeling at the beginning, or I am having an outcome that isn't in alignment with what I was hoping for. And
Hmm.
is there an exit ramp here, as opposed to feeling this path dependence of everyone expects me to succeed. The doctor expects me to succeed. I can't really say how I'm feeling about this. I'm having regret, or I'm having some decisional regret. I want to back away. I want to slow down. I want to change paths, and not
Hmm.
feeling that there's a place that you can say that because you don't feel you can trust. And I think a lot of the really important work you're doing is in centering that detransition experience and letting patients know that this is an okay thing to talk about. And it's
Yeah.
probably an okay thing to talk about even if you're not sure if you're going to detransition. Just
Yes.
maybe like, hey, I want to feel comfortable telling you that I'm having these second thoughts and I want to know how we approach that.
Hmm.
And yeah, so I think that's really, I'm hoping can be a really important outcome, um, to, in terms of, in terms of your work, in terms of how clinicians can not necessarily decide at the beginning, like I can't predict what's going to happen 5 years from now, but of how do you take this, um, how do you incorporate this information as part of the journey? Seems like a really important step.
Yeah, yeah, and absolutely. So I do know a number of clinicians who are starting to, at the outset, communicate to their patients that,
The things
if
you're trying to
you have
say.
a
Yeah.
change in your identity, you're welcome to come back. It's not don't avoid healthcare. And also, I mean, this is part of the informed consent process now, that we do know that for some people, their identity may be fluid. It may shift. It could shift to non-binary. People may have more short-term transition-related goals. And so all of that can be brought into the clinical decision-making and informed consent process.
Yeah.
I think that
That
is
should
a
really be
and
standardized. Yeah.
well, yeah. So I think that is a change that is happening more broadly, at least from what I hear. And I do have, most. all the clinicians who I've spoken to do have people who are detransitioning and returning for detransition related care. So that is something that is shifting in the clinical
Yeah.
space that I'm aware of.
Okay, like I treat Crohn's disease and colitis, and I don't have a practice where I only treat the good outcomes.
Right.
Yeah, like
Yeah.
I obviously am aiming for good outcomes, but I have patients who, despite making good, what we think are good medical decisions, aren't doing well in that therapy, and but they obviously feel comfortable talking to me about it and saying, "Hey, this isn't working for me. Can we try something different?" I know I
Hmm.
didn't want surgery at the beginning. Now I want surgery, or I was thinking about surgery, but I'd like to try that medication again. Like these are conversations I have, and when things don't go well, like my patients know that, oh well, this didn't go well, so I can't go talk to a doctor. I'm treating a condition, not aiming for not only the good outcomes.
Yeah, exactly,
Yeah,
exactly. And so I had a research participant say something to the effect of, we need better research to understand, what portion of people who detransition actually feel fine and satisfied, and what portion actually do feel regret, and that this should be brought back into the decision-making process. So for people who are starting out their transition, what portion of people may actually have a change in their identity and detransition later, but what portion of those actually feel regretful and like it was a negative experience? And I think that I didn't get to talk about the group B, but essentially, this is a group that also, again, in our study, they were largely assigned female at birth. But they had a change in their identity and expression. Many of them were non-binary at the time of the interview or gender fluid, and they actually had a lot of satisfaction with their transition. And so that's also a part of detransition that we see emerging in across not only my study but others that I think also needs to be understood, researched, brought into discussions and awareness. So yeah, detransition is not just one thing. It definitely needs to be studied more and brought into clinical discussions, but not for the purpose of banning gender affirming
to
healthcare,
better
but
inform decisions.
exactly,
Yeah.
exactly.
All right. Well, Dr. McKinnon, it has been absolutely fabulous. It's been a great conversation. I've learned a ton. Hopefully, our audience will also be able to learn from sort of our discussion and from your scholarship in this area. I really want to thank you for taking the time for me this morning, and hopefully, we can talk again in the future about ways that we can work together. Like I said, to keep the project alive.
Yeah, thank you so much for the opportunity. It was great.
Okay, and thank you again.